I request Dr. Anthony to introduce, sir.
Uh, Good afternoon, everyone. I am so happy to introduce Vikas Agrawal to you. As you know, he doesn't need any introduction. Anybody who is interested in sleep surgery and the management of sleep apnea will know him better because he is the president of Indian Association of Surgeons of Sleep Apnea. And he has become a past president now. He's the chairman of Committee of Sleep Disorders, Indian Association of Otolaryngology and Aortic Surgery. He released his first guidelines for the sleep apnea surgery uh, as a president of IA, Indian Association of Sleep Surgeons. He has formulated the informed consent for sleep apnea surgery. As you know, the sleep apnea has got a lot of consent got to be got because of the surgical risk. And he has performed the first tongue-based surgery of OSA in first robotic tongue-based surgery for OSA in India. And is the first to webcast the live robotic tongue-based surgery in the world. First to describe the boundaries of the dissection of adenoid surgery and discovered, and he has presented it, discovered the role of salpingopharyngeal folds in OSA surgery, published the classification system. Oration in the name of Vikas Agrawal at an annual conference of Indian Association of Surgeons of Sleep Apnea since 2015 till now. He is a visiting consultant in the Seven Hills Hospital. He is the director of Specialty ENT Hospital, Satyam Towers, Mumbai, and robotic sleep surgeon and Asian Heart Institute. And his special interest is snoring and obstructive sleep apnea, professional voice, coablation technology, and functional endoscopic sinus surgery. And his experience after post-graduation is 12 years and 3,500 plus surgeries in ENT. So I welcome Vikas ji, Vikas Agrawal ji to start his surgery for OSA.
Thank you.
Hi, are you able to hear me, Dr. Anthony?
Yeah. So I
Are you able
request,
to hear me?
sir, please give me a moment to invite the moderators for the session. I
All right.
request our expert panel for moderation, Dr. MBBS Baparao, sir, Dr. Adip Shetty, Dr. Ranjit Mandal, Dr. Dhrupjyoti Mukherjee, and Dr. Naresh Mohapatra, sir, for moderating this wonderful surgery. Over to you, sir.
Dr. Vikas ji, before you start, I just want to tell a few words. I think after the surgery, you're going to come here, right?
Yes.
Okay, so we have a very, very interesting program called the Fireside Chat. So we're going to have all the faculties on stage, including Dr. Vikas ji, and Dr. Anthony is going to conduct it, Professor Anthony, and you can ask any question to the faculty. So this is going to be something very, very nice. And Dr. Vikas ji, after the fantastic surgery, we expect you to catch your flight and come here. Thank you very
All
much.
right. Thank you. So at the outset, first of all, my sincere pranam to my teacher, Dr. Kirtane. I think sir is there. Sir, please accept my sincere pranam and my thanks to my friend, Dr. Janaki Ram. Now, this case that we have put up for surgery today is a multi-level surgery for sleep apnea in a 51-year-old male, normal BMI around 25, and moderate obstructive sleep apnea with AHI of 21. But he is uncomfortable using CPAP and he is unable to use CPAP for a long time. I'll ask the audiovisual to play the DICE video. It's around a 4-5 minute video. So we'll fast forward it, but you'll get the sound along with the DICE that we have already recorded. Can you play the video, audiovisual?
So here you're watching drug-induced sleep endoscopy with breast monitoring in a 53-year-old male with history of snoring and occasional choking. Got a deviated septum on the left side. You can see the turbinate hypertrophy on the right. Blocked nose because of deviated septum on the left. His body mass index is 25. Overweight is huge. And his AHI on this study is 21. Half of which are obstructive apnea and half are hypertension. As I go inside, you can see there are no adenoids. The salpingopharyngeal folds are also grade 0 by Agrawal's classification. They are not enlarged. And you can see the little bit of snoring because of the uvula
आगे बढ़ाना पड़ेगा.
coming at
मैं
the
बोल
back. If this is still 90, I'll wait for the breast to go in the late 70s. You can see that, as expected, hypopnea could be because of the nose, as well as reduced airflow. Or if this is in the early 80s,
Can you move ahead? Can you fast forward? Audio visual, can you go
Audio-visual.
ahead?
Team, can we fast forward the audio visual?
uvula being long.
Because there is disturbance in the audio, sir.
Because of plexi. But here we are gradually watching that tongue base and epiglottis is also collapsing.
Go to the last part.
Right now,
Yes.
in 76, you can see that when he is lying on his left, the base tongue and the epiglottis is not really obstructing completely. The soft palate is still collapsing into posteriorly. Obviously, he's got a deviated septum on the left-hand side, which I showed you earlier. Now I'll turn him back to the supine position and see what happens. So in the supine position, now he's in the supine position. You can see the collapse of the soft palate, which has become a little more pronounced. Base tongue epiglottis is still not a complete collapse. So obviously he does not require a surgery on the base tongue and the epiglottis. He requires a suspension bridge pharyngoplasty along with septoplasty and turbinoplasty. Thank you for watching.
All right. Now, can we come to the external picture? So, as you saw in the drug-induced sleep endoscopy, we waited till the BIS went to the correct stage. We did the maneuvers on the left and right, and we made sure that the patient is diagnosed correctly. Every tongue base will seem to have a little collapse, but this patient does not require any tongue base surgery. He requires a palate surgery and nose surgery. Now, once we have to do nose and palate and the tongue base is not large, we always start with the palate, because if we do the nose, then the blood will keep on trickling into the throat and it will disturb. We'll first perform the palatal surgery. You can see the position. I am sitting on the head end of the patient. The microscope is put here, and I'm looking into the oral cavity, just as we do the tonsillectomy. So now I'll ask the audiovisual should give the inside picture. The patient is a little head low. Now, can you give me the tooth forceps? Now, this is the tip of the uvula. This is the base of the uvula here. You can see the tonsils are not large, but this patient's soft palate is pretty long. The BMI is not high. It is the length of the soft palate which is the culprit in this case. And therefore, he has a majorly AP collapse, partly lateral collapse as well. So now you can see the tonsils are not large. How much of the soft palate do we need to resect? I have two options. Either I can resect the soft palate, or I can rotate the soft palate and suture it here. In this case, we have taken the consent of the patient to resect the soft palate. So I'm going to start with the tonsillectomy. I'll start the tonsillectomy on the right side. So how much of the soft palate can be resected? You can put your finger on the hard palate and press it behind. Now you can see this is the soft palate which is going at the back and touching the posterior pharyngeal wall. And this is the place which is going and touching at the back. This is the line joining anterior pillar to anterior pillar. So this is the length of the soft palate which is required for the function of phonation and swallowing. And this extra length, we can either rotate and suture or we can resect. So in this case, we are resecting because there is no problem with, we have explained the possibility of a foreign body sensation and the patient is okay with it. We want to get the best result. So I'll start with the tonsillectomy. Now see this tonsil, which is seemingly so small, I'm using coblation at a setting of 7 and 3. Now you can hardly see the tonsil, but when I pull this, now see this tonsil is still here, right?
Yes.
So this is where the tonsil is actually pressing at the back. Who is moderating?
Sir, this is Dr. Archana. And
Hi, doctor.
there are
Yeah.
there is a moderator panel there.
So Dr. Baparao here, sir. from
Dr.
Vizag.
Baparao, sir,
Hi,
Dr.
Bappa.
Deep Shetty, Dr.
Sir,
Deep.
it's Dr. Naresh from Bhubaneswar.
Hi,
Dr.
Dr.
Mukherjee from
Naresh.
Kolkata.
Very nice. So now see, I'm not starting from here because this is the anterior pillar, but the tonsil is all inside. If I try to go in from here, I'll not get the plane only.
Yes,
So I'm using a tooth forceps to pull the tonsil out first, getting into the correct plane, and you can see the anterior pillar being incised.
sir. Any specific reason to prefer the regular mouth gag over the slotted mouth gag?
No, sorry, what is the question?
Regarding the mouth gag you used,
Yeah,
you prefer regular mouth gag over the slotted one.
right. So if you use a slotted one, your space will reduce till here. You'll not be
Okay.
able to see the inferior pole of the tonsil.
Okay, sir. Okay.
Got it? So
Yes,
I
sir.
never use the slotted mouth gag as far as possible. Now see, this is the lateral boundary of the tonsil. Can you see this?
Yes,
Yes,
sir.
sir.
So now this part of the tonsil is creating obstruction at the back.
Yes, sir.
So this is a slightly endophytic tonsil. Now my aim is to give it as painless surgery as possible. Obviously, I cannot perform a painless surgery for sleep apnea, but let's try to make it as painless as possible. So I'll not open up the muscles. I'll remain between the tonsil and the muscles, right? Can you see the fascia?
Yes,
Yes,
sir.
sir.
We are in the plane
So
actually.
far, correct. So far, the muscle is not open. Now I'll take the lux forceps and pull the tonsil medially. Now we'll go towards the lower part. This is not the lower pole as yet. This is the anterior pillar still. And make sure that you are in the correct plane. All these small vessels, if you see, you can coagulate. If you are in the correct plane, the pain and the bleeding will be absolutely minimum.
So you never infiltrate?
No. See, infiltration will make the blood vessels shrink for the time being, which can open later on. So whatever has to happen should happen right now, not after 6 hours. See, after 6 hours, I'll be in Chennai and this patient bleeds. What will happen?
Very true. Sir, is is any particular precautionary medication you have given to this patient, because sleep apnea patients
So-
post surgery as always.
So what I'll do is I'll ask Dr. Vanita. Where is Dr. Vanita? You will talk. So how you do sleep endoscopy and what pre-medication do you give? Can you tell? Give a microphone. Introduce yourself. Dr. Praveen is the anesthetist. He would tell you about the pre-medication. But before that, let me complete this. Can you see I'm
Sure,
already at the lower
sure.
pole of the
Is the
tonsil?
anesthetist. He would tell you about the pre-medication. Is the anesthetist.
Now, if you
there
can
is a-
see, I'm already at the lower pole.
Yes, sir.
Now, if I dissect it here, I will open up the tonsillar artery. Is that correct?
Yes.
And that tonsillar artery can bleed in the post-operative period anytime. So what I'll do, first I will coagulate the length of the tonsillar artery. Wherever the tonsillar artery was going to come, I have coagulated. And then I'll dissect at the medial end of it. Again, coagulate the whole length of the tonsillar artery, and then dissect on the medial end of it. Again, coagulate, or you can go a little intracapsular if you want. Coagulate, and then dissect at the medial end. Now, this is the tonsil. If you want, you can go a little bit intracapsular, and you may leave behind a little bit of tissue at the inferior pole, because sleep apnea does not happen from the inferior pole. All right. So if you want to go intracapsular, you can do that, or you can just coagulate along the length of the tonsillar artery. Coagulate along the length and then ablate on the medial part. So your chances of a secondary bleeding will reduce drastically.
Because do you use microscope routinely during this surgery or just for demonstration?
Sorry, what is the question?
Because do you use microscope routinely during this surgery or you don't?
Yeah. 15 years I've been using the microscope only, because you can see all these fibers very clearly. Can you see?
Yes,
That
exactly.
there's the
That's why
fascia here.
we took up these questions. We should do it under microscope because you see, for the postgraduates and other junior consultants, because sometimes we don't really use, but it will be much wiser if we use. That's what I.
Yeah, because it's always there in the theater, na? See now, how much of the soft palate I can resect. This is the line joining anterior pillar to anterior pillar. So if you resect your uvula here, it will make no sense, because the area which is causing sleep apnea is this part. We have seen in our sleep endoscopy, it's this part which is collapsing. So unless we resect this part out, or if you want to rotate, at least divide it and pull it this much up. You have to rotate it here, not here. This is the part which is the culprit. So line joining anterior pillar is what is required to be. So then, unless you do this much, there is no point of resecting the uvula, right? Otherwise, you can rotate it. If you want to rotate from this line, divide it here and rotate from this line. So what I'm doing here, I'm resecting with the consent of the patient. Now, can you see the contraction?
Yes.
This is the musculus uvulae. It's not centralized. All right. I'll centralize a little better. Can you see the contraction?
Yes, sir.
Yes, sir.
That's the musculus uvulae. So I am still not in the line of the levator palati. Levator palati will be here. So I'm below the levator palati. These are all the fibrofatty tissue which I am dividing. And as I go laterally, I'll be encountering the posterior pillar. So you can see this is the musculus uvulae.
Yes, sir.
All right. So right now I'll complete my dissection for the midline and right side. Can you see these vertical fibers?
Yes, sir.
Can you?
Yes,
Can-
yes. We can vertical.
Can you
Yes,
zoom
yes,
in a
Right.
bit?
Sir, a bit of fine focus.
Can you find focus? All right.
Yeah.
Can you see?
Better.
Got it.
Better.
Better.
So these are the vertical fibers of musculus uvulae. Correct?
Yes.
So I'm dividing the musculus uvulae completely. Okay. On the left-hand side, this is the anterior pillar, and this is the posterior pillar on the left-hand side. Let me show you the entire thing. I have not divided the mucosa. Now, here I come to this is the anterior pillar which I had already incised. I'll show you the fibers of palatopharyngeus now. These are the fibers of the palatopharyngeus. Can you see them?
Yes, yes.
So these are the vertical fibers on the side. These are the oblique fibers. So I'll divide all the oblique fibers. These are the fibers of the palatopharyngeus, right? I'm protecting the mucosa only. And I'll divide all the oblique fibers of the palatopharyngeus so that I can rotate this flap completely lateral. Now this is forming the anterior wall of the pharynx. This is responsible for AP collapse. Okay. Now these are all vertical fibers. I'll leave them. Now what I'll do is I have to resect this uvula, but before that I will try to preserve the mucosa on the pharyngeal aspect, because mucosa is the friend, it's not a culprit. So I'll preserve all the mucosa on the pharyngeal aspect. Okay, sir. And now this flap, the palatopharyngeal flap, has to come laterally. So I will divide this uvula, this palatopharyngeal flap, protecting the mucosa as far as possible. All right.
Yes.
Now I'll
So,
cut it off.
So can I ask a question, sir?
Yeah, please.
So, you said you have taken decision of resection here, but then there is other option of rotating and tying up. Then how you
Yes.
decide on these two options? Like, is there any particular reason to choose
Yeah,
over?
you'll always get better result if this thing is out. See,
Okay.
when you rotate it and suture, there's always a chance that it can open up.
Okay.
Sutures are never 100% friend. You can never be sure of them.
Okay.
Most of the time they will be there. And anyway, when you have rotated, uvula is not functioning anyways. So why
Okay.
to increase the bulk over here?
True.
So
So
that,
majorly the patient's acceptance is the deciding factor for
yes,
you.
yes, yes. See, I have to give the best result, but some patients are of very strong opinion that they want their uvula not to be excised
Right.
because they have read. Now see what I'm doing. I'm dividing very sharply. No loss of mucosa. Can you see that?
Yes, sir.
Now this flap, this was the anterior wall of the pharynx. This was the anterior wall of the pharynx. I'm converting it to the lateral wall of the pharynx.
Right.
One sec, I'll centralize it better. Now see, this was the anterior wall of the pharynx. I'm making it, transposing it, making it the lateral wall of the pharynx now. So by
Yes.
doing this, there's no raw area created. There's no raw area here,
Absolutely. Healing
Right?
is fantastic and in very quick.
right? And the bottleneck area is this only. So many people cut it from here and try to pull it. The bottleneck area is here. So you get maximum dimension opened once you do this. See the difference between the, let me first put the suture, then I'll show you the difference. Now, you can use barbed suture, you can use Vicryl. I'm using Vicryl because I only want the suture to remain there for 15-20 days till the healing. So can you, yeah. Now, we want, this is the pterygomandibular raphe. This is the mandible, this is the pterygoid hamulus. So this is the pterygomandibular raphe. I'll use the length of the pterygomandibular raphe, strength of the pterygomandibular raphe to take this flap laterally. But I'll suture it very, very gently. Now, once I'm using a 2-0 round body Vicryl. And you have to start from lateral to the raphe. You start from lateral to the raphe. Now there are two options. You can come in the upper part of the tonsil, or you can go along the anterior pillar. So I'm going along the anterior pillar. Why? Because I will not encounter any major vessel. So the bleeding chances will be less. This is what we learned from our experience, because typically you are taught to get inside at this point. That's where you get all the vessels. Can you see some vessels over there? So you hit one of those vessels which will bleed. if you do this, the chances of bleeding will be much lesser. And now the whole bulk of the palatopharyngeus, So now this suture, I want to make a figure of 8. So I'll take the whole bulk of the palatopharyngeus, go out in the mucosa. Why in the mucosa? Because I want this flap to completely mucosalize. So you can take 1, you can take 2, as much as you want. Idea is that without pressure, we only want this flap to come like this. Okay? I'll take one more round. And even if it does not become a figure of 8, I'm okay with it. As long as the whole bulk is pulled laterally without any pressure. I'll take one more round, this time little below and coming little up. Again passing through the mucosa, because this mucosa is going to finally lateralized. So we can save some time with the barbed suture, but this part I believe Vicryl is better, because if the barbed suture does not behave in the way it is supposed to be, right? Can you see? I'm just approximating.
Yes.
Yes.
All right.
Right.
And without any pressure, we will want the Vicryl to just keep it in place. No pull. Again, coming just below the anterior pillar, laterally. Now, while coming back, can you give me the... See, I am medial to the pterygomandibular raphe.
Yes, yes.
Why? So that I can use the whole strength of the raphe. These are small points which will improve the results of surgery.
Right.
And that's whole purpose of these programs. Give me the...
Sharing the pearls.
Absolutely. So how you can get the best result? Now, never pull it very hard. If you pull it very hard, it will look very nice on table. But 5 days down the line, the suture will give way.
Yeah. And even the patient may have that discomfort afterwards.
Yeah, because see, if you pull them, so now, can you see that there's a lot of play still?
Yes.
So can you see it's not under pressure at all? Now what
Yes.
I'll ask Dr. Patel is assisting me here. I'll ask him to... Yeah, can you hold it? Now this second and third will be very tight, because this will not transmit the... No, you're pulling. Just remain in that place. Don't push, don't pull. Just remain there. See, this one I've made very tight so that it does not open up,
Yeah.
right?
Yes, sir.
I'll take one more and that's it. So my lateral closure is complete. There's no need to go to the lower pole of the tonsil and take more sutures. It will automatically heal. Now see, this one is very, very tight. Give me scissors, please. You can come out. And leave it a little longer so that it does not give way. Now, my lateral closure is complete. You can see it's absolutely not under tension. It is only directed laterally. It's not pulled laterally. At this point of time, see the amount of opening we have got here. Now, this is the left side. This is the right side. See how much is open. This side is, right?
Yes.
See the difference.
The pharyngeal
Now-
wall opened like a book or a door.
Sorry, what was the comment?
So the pharyngeal wall is exposed like a door, just opening a door or a book.
Yes.
That much space we got.
Yes. Now for the AP collapse, we want to support the tongue. We want still the snoring to go away completely. I'm using a non-absorbable
Vicryl.
barbed suture. So again, the non-absorbable barbed suture will remain for life. This is what actually the absorbable one was being used already, only on the side. So we made two changes. One is we use the non-absorbable barbed suture. I'll try to show you the suture if possible. Are you able to see the barbs on the suture?
Yeah, you
Not
can see the bobs. Yeah, it starts after
Yeah.
some time.
Yeah. So and there's a loop at the end. So what I'll do is, now again the pterygomandibular raphe is here. And let me show the loop. It's very important for you to see the loop. Can you see the loop of the suture?
At the end, there is always
So the picture is not centralized. Kindly.
Acha, all right, all
Yeah,
right.
we can see the loop mostly.
All right. So I want the loop to remain lateral to the raphe.
Right.
So I'll start almost 7 to 8 millimeters lateral to the raphe. So the raphe is here. I'll start here. So that the whole strength of the raphe is utilized. I'll start lateral to the raphe, around 7-8 millimeter lateral. Sorry. Go very, very deep inside through the pterygomandibular raphe. Come towards the supratonsillar area. Hold on. Actually, this microscope was coming in my way, so I have to change my grip. Give me a moment. Because see, this suture is going to remain in the patient's body for life. So you have to put it very, very nicely. Okay, can you see that? This is right in the supratonsillar area.
Right.
Yes, you can see.
All
Quite a
right.
big chunk here.
Yes, very deep. Because this is going to lift the soft palate anteriorly. And this is also going to support our base of tongue. Now see this loop. This is our raphe and we want the whole loop to go inside, but sit lateral to the raphe.
Okay.
All right.
Yes, sir.
Still, it is not completely gone. Give me a mop.
It's almost gone in.
No. But that's not enough.
A bit is still.
Can you see? If I leave it like this, I want it to completely internalize. And the mucosa has to grow over it. But if I pull it very, very hard, it will pass through the raphe. Give me a knife, please. So see, I have already reached the raphe. It's not getting pulled. What I'll do is, I'll take a knife, make an incision into the mucosa.
Release the mucosa above.
Yeah. So that the mucosa will grow over it. So that small incision, I'm just trying to bury it completely inside. Now give me the, because see, this is going to stay in the patient's body for life. It's like an implant. You have to put it properly. It's still not to my satisfaction. Give me the knife, please, sister. Give me the knife. Otherwise, it will show up. I'm making a mucosal incision to completely bury it inside. Maybe I should have started a little more lateral, 2 millimeter more lateral. This is the problem we face. Initially, when I started at the raphe, I faced a lot of problem because this part will show up later on. Anyway, if required, you can just take a Vikas suture over it.
Yeah, that's exactly. I was thinking about
Yeah,
it. Just
it has to be completely internalized. I'll not waste time on this. I'll take a small Vikas suture over it. All right.
Okay.
I have already made the mucosal incision, but I'll still make sure that it doesn't show up later. All right. Now, we are already in the center of the soft palate. So I'll go across the midline, enter from the same point. If you start here, then it will show up here also.
This is very
So
important.
start a little 2 millimeter behind and go across the midline very, very deep. Then what will happen is that your
Reaches.
barbed suture will pull it. Can you see this?
Yes, yes.
It will pull it anteriorly. Why? Because pterygomandibular raphe is the anterior. Now at this point of time, we now need to go on the left side. So we'll change the tube to the left. Anesthetist, please. Dr. Praveen, while you are changing the tube, why don't you keep talking? Microphone to Dr. Praveen, please. So Dr. Praveen will change the tube to the other side. External camera. Yeah, you change it. External camera. So I can take questions and one microphone to Dr. Praveen. Is there any questions so far? So what I've done is I've taken it laterally, I've taken it anteriorly. So AP, lateral, both the collapses are taken care of. And we saw that tongue base was not the problem anyway in this case. Whatever little collapse was there now, tongue will sit on this, barbed suture, this suspension bridge, and it will not collapse. So that way the snoring and the sleep apnea will come down drastically.
Because any advantage or disadvantage of nasotracheal intubation in this particular case?
I have to do the nose. I have to do the nose surgery also.
Do the nose surgery also. Right.
Therefore, second thing
Otherwise,
is that
had it been the fact that you didn't have to do any nasal surgery, then would you prefer a nasotracheal or you don't?
I will still prefer a oral. Why? Because my assessment of how much soft palate I have to resect, that is more accurate when there's no tube, right?
Okay, because you cannot press the palate nicely if the nasotracheal tube is in. Right.
No, so see, this 5 minutes of change of tube do not matter.
Doesn't matter.
What matters is that I have to make my assessment. See, you are making a permanent change in somebody's throat, right?
Yeah.
So there are two questions, sir.
Yes.
So Dr. Shweta Shinde.
Yeah.
Good afternoon, sir. I want to ask whether the patient will have nasal regurgitation while eating.
Okay, the answer is answer lies in another question. Have I touched the levator palati muscle?
No, sir.
Have I touched the tensor palati muscle?
No.
These are the only two muscles which are responsible for swallowing and phonation.
Yes, sir.
So that cannot happen. Cannot. Right?
Yes, sir.
So see, temporarily because of pain, if the patient is, not swallowing properly for a week, 10 days, that is possible. But this patient will have liquid diet. One sec. Can you put this a little down? Hold on. My mouth gag is not properly applied. No. Thank you. Yeah. See, you have to get the maximum space. Therefore, I don't use the slotted blade.
Okay, sir.
Now,
Okay.
Fine. And give me a tooth forceps. So what I'm doing is now, I had put my throat pack on the right side. Now I'll take out the throat pack and put it on the left side, so that the endotracheal tube will go on to the right as much as possible. So you'll get more space on the left. So these are small wastage of time, I understand, but they make your work much more precise. So the answer to Shweta's question is that this patient will have normal swallowing after 6 hours. He'll have ice creams after 6 hours. And even this patient will be fit to be discharged by the evening, if you want. Obviously, we keep them overnight because it's a multi-level surgery. But if you want to discharge this patient, even with a packed nose, he is good to get discharged. This is what I'm saying. It's a very, very predictable surgery. Now I am going for the tonsillectomy on the left side.
Yes.
Clear vision is okay?
Okay, sir. Can we put more questions? One
Yeah,
more.
yeah, why not?
Question by Dr. Karthik Raj. Won't the patient get halopharyngeal insufficiency if more resection is done?
Yeah, if you resect more, yes. But therefore, I showed you the boundaries very clearly.
Yes.
I have not gone till the levator palati. Can you take it? Yeah. Lower pole is not seen, all right. No, but the tube is coming in my way. Chalega.
Sir,
Now
another
I'm going for the left tonsil. Yeah, go ahead.
Dr. Santanu Saha. Question is, any changes in voice after surgery?
Almost nil. There will be some change in resonance, but not in the nasality. I hope you understand what is resonance and what is nasality. Nasality is a function of the soft palate. So if my soft palate is damaged, my voice will become like this. Can you hear me?
Right.
This is the effect of this kind of voice will happen if my levator palati is damaged. I have not done that.
Okay, sir. Okay.
100% I have not done that. So it's impossible. Surgery on a voice professional. But if it is a singer, then the resonance will change. Because
Team.
obviously the dynamics of the pharynx is changed.
We lost the picture, sir.
Oh.
Okay.
Go ahead.
Sir, please give example of the resonance change also, sir. I know your
No,
skills.
All right. See resonance. If I have, say, my nose is blocked. If somebody can block my nose, can somebody help me block my nose? Somebody who's not washed up. Just block my nose, na. नाक बंद कर दो मेरी. Correct. So now my nose is blocked. Can you see my resonance? It's totally a hyponasal voice.
Yes.
All right. Thank you. So, and see, the resonance is I can do a lot of resonance change by manipulating my pharynx in different ways. So suppose if I have to talk in or sing in the voice of Jagjit Singh, so what will I? बात निकले. So this is Jagjit Singh. If you have to sing in the voice of Mukesh, मैं ना भूलूंगा. This is Mukesh. Now see, there's a lot of change in resonance. So that fine change will happen. All right, now I am at the lower pole of the tonsil. And not only resonance, there's a change in the different frequencies, overtones and everything. That's a purely professional voice thing. Now see, this is the lower pole. Now I am going a little bit intracapsular over here, not leaving behind too much of tissue, but making sure that this patient will not bleed when I'm in Chennai. Fine. Suppose if it bleeds, Dr. Patel will take care of it, but 99.9999% nothing should happen.
It will not.
Backup is all there, but you should make sure that complications do not happen. They can still happen. Now, see, there's a lot of tissue still inside. Can you see this? I have gone intracapsular, but there's a lot of tissue, so I'm reducing it further. I can't leave tonsil stones. This is precisely the place you get the tonsillar artery, and therefore I have gone intracapsular. But luckily in this patient, the tonsil is small, so the artery also will be small. So the risk is not much. Many times you get very, very large tonsils. No amount of live lymphoid tissue has been left, so that he should not get a feeling of tonsil tag.
So there's one more question from Irshad Ismail Tamboli.
Yeah.
Can we use monopolar cautery in UPPP? And how
No,
much difference will be there in pain threshold by using monopolar and
No,
coplator?
pain is immaterial. You will create fibrosis. You will make soft palate to a hard palate.
Okay, sir. Okay.
Soft palate is supposed to remain soft.
Got it.
So no way. So what will happen then you cannot resect uvula. Then you cannot resect soft palate. You have to preserve mucosa. Why? See here, because it's a soft technology I have been using, I have resected so much of the soft palate. But if you are using a cautery, this will cicatrize in this way. It will not let the soft palate go up. And there will be BPI. With the same surgery, there will be a BPI. Even if you have not touched the levator palati. All right. Now let me take that. These are the vertical fibers of the palatopharyngeus. These are the horizontal fibers. I am cutting the horizontal fibers of the oblique fibers of the palatopharyngeus and dissecting this mucosa very, very sharp.
Well, Vikas, any advantage of using a non-absorbable bulb suture over the absorbable bulb suture?
Yeah, absorbable will not work after 6 months. It will get absorbed. I want it to remain for life, na?
That's great, but by that time the fibrosis and other mechanisms pulls in and
No, I didn't get your question.
no. If it is done with the absorbable bulb suture,
Now see, there are so many vessels. Where did it open? With my forceps. See, I operated here, but I was pulling it with my forceps.
yes.
See? So
Yes,
we are operating on a pretty vascular structure. I pulled little hard with my forceps,
Mhm.
right?
Right.
So it opened up here with my forceps, not with my where I was operating. Now, if it opened, I am coagulating it along the length.
Right.
Otherwise, it will open up later. And that's the reason I said I do not do any blind suturing in the fossa. All the sutures come from the anterior pillar. All right. Give me the vehicle, please.
So in this patient, the tonsil is very small. So whenever it is very large, so have you is there any difference between the kind of resection you do or any problem do you?
Yeah, so see, the large tonsil are a double-edged sword. First is that you will get a very good result of your surgery. Why? Because you receive large volume. So your airway volume increases. But the blood supply of the tonsil is also very large.
So you expect a lot of oozing and
correct. So many times you go intracapsular, completely intracapsular.
okay.
Why? Because you expect that in the post-operative period it can bleed. Can you give me let me see where it is coming from. So if there is any red thing, you check it right now. Don't leave it to the end, because you can see what is bleeding just now and you can tackle.
Right.
Give me the coagulation. Let me see what is bleeding. All right. So the pillar retractor. Maybe it is the okay. So from where it came from here, I'll coagulate it. So you don't get any big vessels near the anterior pillar, so I'm fine. Nothing big can open up over there. Vessels are all in the fossa, tooth fossa. All right, now we only need to take this whole palatopharyngeus and direct it laterally. So I know that there is a vessel over there. This is too quite lateral. I'm trying to avoid that vessel. All right. So even if I just direct it like that, you may go once again, but this much is enough. I do not want to encounter that vessel again. And this time I'll come and remain medial to the pterygomandibular raphe. And see, this will nicely just sit around here. Can you just remove this?
Yes, absolutely.
Can you remove the barb from my way? Just take this barb out. All right. And can you just hold this? Very, very gently. Yeah, can you just hold it? Stay. Step, step. But this step should be below the knot. Thank you. So this one is, now I can tighten it without any pressure. So this practically will never give way. If you use this small technique anywhere where you need not put pressure on the suture. So now this one I'm making very tight, and the third one absolutely tight. So this will not give way for sure, and my surgery will not fail most likely. And this I've learned in the last 10, 12 years that, all right, leave it. Scissor. So now you can see how wide the opening of the pharynx has become. This is not completely pulled, but it is only directed laterally. Suction. Wand. Now I only need to complete my AP collapse. All right. So see, this whole pharynx is box. Now for the AP, I will just go to the left side and then come back to the right. And that will be the end of the palatal surgery. This surgery gives results as good as a zeta pharyngoplasty. So it's a pretty aggressive surgery, but with at least 5 times less pain and morbidity as compared to a zeta. Now I'll try to go lateral to the raphe. If possible in one go. Let me see if I can reach. Can you give me? Otherwise, I'll have to go in again. Now see, I have reached lateral to the raphe. Can you? Are you able to see, or it's not centralized?
Yes, sir.
Seen, sir. Seen.
All right. Now, see, from right to left, this is the suspension bridge suture.
Yes, sir.
What is the effect? That it cannot go behind. Why? Because it is suspended anteroposteriorly. But
Yes,
when the patient swallows, there is no problem in moving superior. So the swallowing is fine, voice is fine, but snoring is not allowed, because this part which was collapsing, first of all, the height has been, the length has been reduced, and whatever was there has finally been not allowed to vibrate because of the suture, and the tongue will also rest on this. So now again, we'll have to give 5 minutes for this, going again from the same point, coming to the supratonsillar area of the left side. All right. Then again entering from the same point, going very, very deep, the central area. See, no one actually earlier decided to go across the line, midline, because they thought that if you go across the midline, you will get VPI. But we are in the area which is below the levator palati. So there's no question of VPI. This is for AP collapse. The AP collapse cannot happen. The tongue base cannot collapse because it will sit on this, at least the upper part of the tongue base, because there is no surgery for the upper tongue base. Can you show me? I want to go lateral to the raphe. No, I want to go lateral to the raphe. Can you? No, we don't need to change. Can you just show me? See, we can either change the tube, or we can just struggle a little bit and do it. Thank you. So now this is the raphe. I want to come out lateral to the raphe. If possible in one go, not otherwise I'll come again. So can you see I'm lateral to the raphe?
Yes, it can be, sir.
I'm absolutely lateral to the raphe. Now, we can simply cut it over here. But what I'll do is, I will make a U-turn again. And further lock it. So I had gone from right to left, left to right, and a U-turn in any direction. That doesn't matter, but a U-turn. So that, let me just show you where it comes out. So that when you make a U-turn, now the suture is completely locked. Now it cannot move at all. And simply cut, there is no knot. That's the surgery for, all right. What is the net effect of this surgery? Can I have some instrument?
The AP collapse is good.
AP collapse, see, it cannot happen because there is a restriction, but it can move superiorly very easily. When the levator palata is contracting, there is no hindrance. Now
Yes.
this part I have left some mucosa. So this mucosa will reduce the foreign body sensation. The lateral collapse, I have already taken, this case was not a predominantly lateral collapse. This was the AP collapse, but this part forms the lateral collapse. So I have just, taken it laterally so that this part which was forming the lateral collapse will now be restricted because of this fibrosis here. But this is not the best surgery for lateral collapse. You should have done a little more over here. In this case, the lateral collapse was not much more, so I've not done. Otherwise, I've taken few stitches inside here to support the lateral collapse even more. So my palate surgery is over. Now I'll go to nose surgery. So we'll change the stance. Nose, we have to do septoplasty and turbinoplasty. I'm sure everybody knows very well how to do septoplasty, turbinoplasty. So if your next case is ready and you want to leave, you are absolutely free. If you want to see, then we'll continue with this on the
Can I have a question?
head high, please. Yes,
Dr.
please.
Dr. Vikas,
Yes,
can I have a question?
Please, go ahead.
Myself, Dr. Manoj Mukherjee.
Yes, Durgapur.
Can I have a
Yeah,
question?
Bardhaman.
Please, go ahead.
Durgapur.
No,
Myself,
Bardhaman, sir.
Dr. Manoj Mukherjee.
Bardhaman. All right.
Yeah.
Yes, Durgapur.
So,
Bardhaman.
actually, can we avoid the bud suture by excising few millimeter of the soft palate, extra few millimeter?
No, so, I mean, that's a very, very good question. See, if you hit a 6, then there's a chance of getting caught at the boundary.
Yeah.
So what is the best way to approach the boundary? To hit a 4. Never hit a 6. See, if you lift the ball,
Okay.
then you are not in control. Head high, head high.
So, so in expert hand, we can do that. Is it?
No. All people who have got caught at the boundary were experts. Even, see, can you give me the light, please? Patties. Audiovisual, can you shift to the, no, the endoscope is very dirty. Give me something to clean.
And
No,
another,
Dr. Manoj, try to understand.
Yeah.
You can't give complications. Even if we give a little 80% result, you're fine. So if you try to go absolutely close to the boundary line and the healing does not happen as per your wish, then what will happen? Can you put it back? Can you put that extra few millimeters back on the patient's?
definitely not.
You cannot. So always, see, I'm already very aggressive. My friends, call me whatnot. But you cannot go more aggressive than this.
Yeah, thank you. And another question, can you call it ESP? I mean, expansion sphincter pharyngoplasty?
Yeah, so I have tried everything. I believe that once somebody can have a AP or lateral collapse, that collapse keeps changing. I don't know how is the picture quality. How is the picture quality down there?
Not
Can you do
so
the
good.
white balance? I'm operating at another center. I'm not operating at my own center. Can you just white balance? Hold on, hold on. All right. All right. Can you
It's
see the
better,
turbinate
it's better.
hypertrophy on the right side? Now,
Yes,
this
yes.
kind of turbinate, the sinuses are clear. The CT scan is done. It's majorly a septum turbinate issue. Now, this is a very common problem. Almost 50% of the population has got deviated septum and turbinate hypertrophy, which is more accentuated with the allergies. This patient does not have any significant allergy, but see the kind of turbinate hypertrophy he has. And unless we create a lot of space in the nose, he'll still mouth breathe. If he mouth breathes, his sleep apnea will not go away. So I'm injecting the septum, starting
Still
from the
fine
posterior.
focus is required, sir.
Sorry?
Still fine focus is required.
Still fine focus is all right.
So some fine tuning will be requested.
All right. Give me a moment. Now see, septoplasty for sleep apnea is a little different from the routine septoplasty in that we have to support the nose, but we have to get maximum passage. In this case, this is the area which is the most important, the bottleneck area. Can you suction, please?
The valve area.
Can you see the nasal valve?
Yes. Yes.
Left nasal valve. Now somebody will say, I'll do an open nanoplasty. You really don't need to do an open surgery. Right side, you can see, no, we can make it better. Is it any better?
No, sir, no.
All right.
It's good. It's
White
good.
balance
It's okay.
done, sir. White balance.
Still can be.
White balancing has been tried. So I'm first out fracturing this inferior turbinate so that you can see a little better. All right. So this much space is on the left side. Suction, please.
This is right.
Right.
This is right
This is the
side.
right nostril. Now, my aim is to open up the nose as much as possible without giving an empty nose syndrome.
Right.
All right. So now, fine. So now give me a knife. Sister will show the incision. So as radical septoplasty as possible. Now this is the anterior rim. I am still on the skin. This is the mucosa.
Will you call it the transfixion incision or no?
Whatever you want to call it, transfixion or whatever. Honestly, I'm not very good with names. All right, so now we'll take the suction seats. All right, so we are in the plane. We'll change the suction now to septoplasty suction. Because the most common surgery I got to perform in my entire career of 25 years has been septoplasty.
It's true. Severe enough of surgeries.
And it's a wonderful surgery. If you do it nicely, very predictable long-term results. Very, very predictable. Only our diagnosis has to be correct. That whether it was an allergic problem or a structural problem. So now you can see the little spur. I know that my flap on the left side may get torn. I'm ready with it. So I'll only preserve the flap on the right.
So before you resect, tell us the boundaries
Of
your resection.
Oh, okay. So no, so I will only say, I'll only tell what we need to protect. Rest everything goes out. Now see, what is the area, what are the points on which the shape of the nose is dependent? Can you see this opening like a swivel door?
Yes, sir.
Yes, sir.
This septum, every septum, this moves like a swivel door. This part, when I'm moving the anterior part right, this part is moving left. See it again. Any confusion?
No.
This is the area, anterior nasal spine is the area on which this axis is rotating. Correct?
Yes, sir. Yes,
So
absolutely.
you just remain behind that and resect everything. Nothing will happen. Now, what was the other point? The point joining the keystone area, where the
Yes.
upper lateral cartilage joins the the septal cartilage. So if I go up and remain 2 to 3 millimeter below and behind that line, that point, now all this, I can remove this whole cartilage without any fear of disturbing the shape of the nose. Now it's important to be in the correct plane on the right side as well.
Absolutely.
Otherwise, it will simply keep on bleeding. No, I've not got the correct plane. Can you see?
Yes, yes.
Give me another. No, suck it, sister, please, suction. All right. Thank you. No, I've not got the correct plane. No, I've still not got the correct plane. Remove it. So I'll wait for a minute to get the correct plane. Unless I leave it. So the correct plane is this one.
Yes.
I'm sorry, but this is a very basic surgery. Septoplasty is the most basic surgery, but unfortunately, it is not really taught. People believe that everybody is a master of septoplasty before even doing it. And see, even after doing thousands, I'm still not in the best plane. This is not still the perfect plane. It's a manageable plane. There's still a very fine layer still on this septum. This one. Perichondrium, a very fine layer is still on this septum. That's the correct plane.
Yes.
All right.
Got it.
That's the correct plane.
Some are not pericardium left.
Sorry?
Some pericardium is added.
This is the correct plane. This is not the correct plane.
Yeah.
Right.
Now I'm elevating the flap right till the back and right till the bottom. So my right flap is completely saved. So I do not care what happens to my left side. Now see, what was the nature of this cartilage? This was always going laterally. Now I still need to save upper 2 to 3 millimeters. So see, this is the area. This is the internal nasal valve area. So I'll only save 2 to 3 millimeters at the top. See, I'm leaving behind 2 to 3 millimeters. That will be enough to not let the nose collapse. Supratip deformity will not happen. Sorry. And now I'm free to, because see, that was a very narrow area. Now I'm free to remove everything. Suction, please. Still, this part needs to open up more. Now, where is the skull? Question will arise, where is the skull base, right?
Yes, sir.
Can you see that this part is completely crooked on the left?
Yes,
so if I do not, so the skull base will only come when middle turbinate arises, right? Only after the middle turbinate. It cannot happen. It cannot come before the middle turbinate.
Okay.
So this is the cartilage Now this is the bone. Can you see this is the bone?
Right.
The thick part of the bone is always below the frontal sinus. So I've gone absolutely high, left only 2 to 3 millimeters. So this is the perpendicular plate of the ethmoid. That is the area which is below the skull base. This one. So I will not pull at that area. Just give me a scissors. All right. See, even the perpendicular plate of ethmoid is not straight. On the CT scan, we have already seen that. So you can simply cut it into small pieces. Now, that's very small piece. You can simply remove it. Now that it is already cut into small pieces, so I have not gone into the skull base. Now, let's do the inferior part. This part, the septum was maximally deviated. That was the spur. So give me a knife, please. Now, all this needs to come out. So as I said, the flap on the left side is bound to open up because of this spur, and I'm not really inclined to protect it because my right side is perfectly normal. I'll just ignore. Lux, please. Lux. See, this patient, we have to start on blood thinners again after 1 to 2 weeks. 2 weeks is the max we have got from the cardiologist. He has some issues because of which he's on blood thinners, but there's a complete fitness for the surgery. He's unable to CPAP, so obviously only with the cardiologist's written clearance, one physician and one cardiologist, we are doing this surgery. So we have to make sure that nothing is left to chance. All right, now let's see what all still needs to be done. Leave the flap, actually. All right, so the external nose is normal. Inside, you can see how much of space is created on the left. This flap we have opened.
Because can you just suck in a little?
Lux. Sorry, what was the question?
No, it's not a question, just a suggestion. If you can just suck it a little so that we can see.
Yeah. All right.
Yeah. Better.
This will stick in 2 days' time.
Absolutely.
Now we need to perform turbinoplasty. See, the left side turbinate is anyway not that big, but right now it is in a decongested state.
Yes.
When we started, everything was obstructing.
Yes.
Now, turbinoplasty is again, I believe, very, very important armamentarium in your tool in your armamentarium or technique.
Right.
If you can do a good turbinoplasty, now this patient, there are 3 parts of the inferior turbinate: the anterior part, middle part, and the posterior part. You can see the most posterior part is completely polypoidal.
Yes.
And the inferior part is again completely polypoidal. So many a times I use sonopet and piezoelectric. I'll not use any of that stuff over here. I'll just use the microdebrider.
Yes.
Check on the suction cautery. Is it working? Let me see. Let me check. So I'll first check the suction cautery because I'll need to cauterize the turbinate. No, give the foot pedal to me. I'll first check my suction cautery before cutting, because I'm going to use it. Can you reduce the sound? No, it's not working.
Because can you use the coblation also for this?
I can use the coblation as well. Web suction cautery. No, it's not working. Now it's working. Fine. All right. So now you can use coblation also, but for this, so I'm using debrider to debride the lower part of the turbinate. And see, I have not injected. All right. I'm removing all the polypoidal tissue completely. So polypoidal tissue is full of mucus glands. So the upper part is full of serous glands. The lower part is full of mucus glands. Now this post-nasal drip will not happen because the sinuses are clear and have come till the bone. Now what I'll do is this turbinate is anyway not too large. So I'll just try to reduce the bone as much as required. In this case, left side, the turbinate is not very large. I'm just using a scissor and debrider because everybody can use it. So I'm not showing piezoelectric and all. So you can simply get a very, very good clearance. Suction cord. Now, as you said, you can use coblation, but cautery, the chances of a rebleeding in cautery is much lesser. And here we want to shrink the rest of the turbinate. That's why we are using cautery. Now, if you go here and remove this part of the bone, you will get the blood supply. Therefore, I have not removed this part of the bone. No, give me this. Cautery is not working. No. You have to make the cautery working. Sorry. Just check out. Give me a moment. I want to just cauterize it till the cautery is getting ready. I'm out fracturing. One sec. So there's hardly anything to out fracture here. Now you see how much of space is already created. Yes, now it's working. It's very high.
Wonderful.
No, make it less. Yeah, still it's very strong. Reduce the power. Reduce the power, yeah. To our regular that we use. So I'm cauterizing all these areas. So make sure that you do not leave raw bone over here. And this nose will never give trouble again in life, but because this turbinate cannot hypertrophy, even if the patient is allergic. You can see the valve area completely open on the left.
Yes.
Dr. Baparao, any questions here?
No, sir. Absolutely fine.
Completely. Now we'll come to the right side.
So you mind using the coblet on the other side?
Yeah, as I said, you can use, but coblator wand is a little large. Sister, can you, if the cautery doesn't work, I'll use that. All right. So let me suck out the blood from the, now see how large is the turbinate. So on the left side, I started in the front. Here, let me start from the back. So the posterior 1/3 is always polypoidal.
Yes, sir.
See how much of space this. The lower end is always polypoidal. I have not injected. There's no bleeding. And this tissue you still have the serous tissue in the upper part. So there's going to be a little bleeding from here, which I expect. Now I expose this bone. So what I'll do is I will elevate the flap if possible. Sometimes you get a very nice plane. Sometimes you do not. But my aim is only to reduce this bone. Anyway, the bony part in this patient is not very, very pronounced. So I'm using a stout curved scissors. I'm not using a straight turbinectomy because what happens, you go and hit the blood supply of this turbinate over there. Therefore, I'm using a curved stout scissors. Debrider, please. Now, you are not messing up with the blood supply of this turbinate and the nerve supply of this turbinate, which is here. If you mess up with the blood supply and the nerve supply, then only the question of empty nose syndrome arises. Now see, can you see I have almost preserved, and how much time it took? 5 minutes at the most. And you can cauterize. So you have given me the cautery, it's not working. Can you increase a little bit? Yeah, this is perfect. Thank you. So you don't need to cauterize too much. It's only to, now see, there is still some swelling over here. If you want, you can go inside and do a submucosal cauterization. If you want, you can use a sonopet and remove the bone from that part. So now this is a perfect, and if you require, you can out-fracture this turbinate. So this is a very low-tech turbinoplasty, but which will always give you a very nice long-term result. 4 to 6 weeks of, see this part, you can go further inside and coagulate a little more if you want. Submucosal coagulation. So this will never swell up so much that. All right, now give me the gel foam. So one aspect of septoplasty is that, why do you get complications? Because there is some hematoma inside the septum. Here, first of all, there is no bleeding. But now my pack, get the pack ready 1 by 2. So the pack will only cover the lower part. So if you put some gel foam in the upper part, now we have nasal bones on the side and septum in the middle, and you pack this area with gel foam on both the sides. Just let me see if I need to remove a little more cartilage or not. Can I just hold it? Am I reducing? Am I removing less? Give me a knife, please. Let me remove a few more millimeters because the right side was not as nicely open as the left. I possibly, how are we doing with the time? I'll be over in 5 to 7 minutes. Moderators, how are we doing with time?
You are perfectly on time. We are comfortable. Very comfortable.
All right. What is the time now? All right. So I'll be over in 5 to 7 minutes. Maybe a few more millimeters if you want, you can remove. Or if you want, you can just score it and leave so that it becomes straight. Leave it. So there is anyway nothing more that you can do here. Gel foam. This is simple gel foam impregnated with some hemostatic solution. If you put good amount of gel foam, you will forget about synechia and hematomas. Because the lower part anyway can be taken care of with the nasal pack. It's the higher part where you get the hematoma. So in last 10 years, we have not, I had seen hematoma in one patient who had got a very high blood pressure. In the post-operative, his blood pressure was sleep apnea patient. His BP was 200 plus in the post-op. When we removed his pack, immediately there was some swelling of the septum because of high blood pressure. We had to aspirate periodically. But apart from that, you don't get any hematomas, you don't get any synechia. This you'll remove after 2 days when the pack is removed. I'm only packing the upper part of the septum. of the nasal cavity. All right. Now I'll use something called rapid rhino for nasal packing, because we have done good amount of turbinoplasty. So are you able to see this?
Yes.
So this is called rapid rhino. And we'll put it inside and inflate it. Can you, sister, just show by inflation? Just inflate it a little bit. As you put it inside, inflate. It's going to inflate more. Can you see? It will keep on now deflate. So this will make sure that your turbinate does not bleed even if you leave an artery open. What I've done, I've just put it along the floor. Upper part we have already just show. And Dr. Patel is now inflating it with 7 to 8 millimeters of air. Now you see it has exerted pressure, and whatever was there in the septum has already come out. So our surgery is over. Now we'll have a look inside. So you have to check the pressure. It should not exceed, say, 100 millimeters. So right now, the beauty is that suppose if the patient comes out of anesthesia and his blood pressure goes high, you can just increase the pressure and the patient will still not bleed. And after extubation, you have to reduce the pressure, so that if the pressure is too high and you leave it for a long time, then the patient will get, hold this. Now, this is all the collected blood from the nose.
Because one more question. Like after surgery, you said that you'll be allowing the patient to have, ice cream after 6 hours, right?
Yeah, NBM after 6 hours.
And when do you think you should start giving solid diet to the patient? How many days, or solid diet? Normal diet.
Solid diet, we usually, semi-solids, we start from day 4, day 5.
Semi-solid.
3 days of liquid.
Okay.
Now, one thing more before I stop. Can you put it down? So you must make sure that there's no gel foam in the nasopharynx. Right? Because that's the nasopharynx.
Right.
Make sure that there's no gel foam, because that gel foam which we kept should not come down and obstruct the airway after extubation.
That's right.
Fine. So there's no bleeding. This was all collected blood. No bleeding at all. I'll take out the throat pack as well.
Okay.
Give me something to take out the throat pack.
So there's another question from Dr. Sai. After addressing the oropharyngeal issue, if the patient mouth breathes, do we still have an uncorrected sleep apnea?
Yes. Very good question. See, if the patient is a mouth breather from childhood, just your surgery is not going to turn him to a nose breather. So you still need to give external camera, please. So you still need to give him a good amount of myofunctional therapy, and you ask him to use a chin strap. We can go on that side so they can do their work. So you still have to give them good amount of myofunctional therapy and chin strap, so that patient learns to nose breathe, because it's a habit of so many years. And that's the commonest cause of failure. I'll put my mask down. That's the commonest cause of failure of sleep apnea surgery, mouth breathing.
Myofunction therapy, what was it, sir?
Yeah, so basically it's a little nice name for physiotherapy. So we ask them to swallowing therapy, breathing therapy, and this and that, like physiotherapy. Physiotherapy for the airway.
Vikas, thank you so much. It was an excellent demonstration.
Thank you.
Thank you so much, sir.
Sir, even in the post-lunch session, the hall is almost full, sir. I'm leaving about the online attendees. Physical attendance is very good, even in the post-lunch session. So thank you very much, sir.
Most welcome. Thank you.
Thank you.
See you, sir, in the evening singing.
Yes, I have to leave for the airport. My flight is at 5.
We all are eagerly